Man, am I hungry.
Thanks for calling Just Pizza. How can I help you?
Yeah, I'm starving. I was thinking about ordering hamburger or pizza.
Well, you called Just Pizza, so I can put hamburger on a pizza, but if you really want a burger, you're gonna have to call Just Burger.
Right. Now, let's go with the pizza.
Okay, so a ground beef pizza.
Well, that depends. Beef can be kind of bland, and I like meatballs, but I don't feel like them today, and
Italian sausage is kind of spicy.
Well, our ground beef is full of flavor, but I wouldn't call it spicy. Listen, you sound like you really want a hamburger. Why don't you give Just Hamburgers a call? They make them really good over there. Love that place.
not now. I'm excited about this pizza. Let's go ahead and add some onions to it as well. I like grilled onions, but raw onions are a little bit better from a nutritional standpoint, so let's go with that.
Okay, so what size pizza do you want?
Hey, are you ordering pizza? Can I get in on that?
Yeah, sure. Hang on one second. What do you want?
How about pepperoni?
I'm kind of craving hamburger.
We can do both.
Yeah, sure, why not?
Don't get onions, though. You know I don't like onions.
Yeah, I know.
All right, let's go with a large pizza.
I need to add pepperoni, but kill the onions.
Got it. Your total is 1702. Should be ready in about 20 minutes. Can I get an address for that?
Big problem here with all this fat stranding around here.
Right there, yeah.
Yeah, this is going to be a real problem.
You guys the hamburger pepperoni pizza?
Yeah, that's me.
Sorry it took a while to get here. They didn't tell me where in the hospital I was supposed to go.
There's onions on this. I told you don't get onions.
That's what I said. I said no onions on the pizza, and there's onions.
You said grill the onion.
No, I said kill the onions.
No, you said grill the onion.
Kill, as in no onions.
Well, Sarah, that was unfortunate.
I agree, David. Hopefully no one actually orders pizza that way. I'm sure we've both seen communication issues like this in the emergency department.
That's right. And this is an important issue because we know breakdowns in communication are responsible for a high percentage of medical errors. Consultation is a common form of communication in healthcare, especially in the emergency department, where consultation may be obtained in at least 40% of all ED visits.
So let's define it. We can think of consultation as seeking the formal recommendation from a specialist. And just like any procedure, it's a skill, and there's necessary components we need to think about.
Absolutely. And these components include synthesizing the clinical data, understanding the background of your consultant while anticipating their questions and needs, effectively structuring the consult, and always maintaining professionalism.
What is clear is that when we standardize communication practices in healthcare, we minimize the risk of adverse patient effects. In particular, using a standardized model can help to ensure the quality and accuracy of the conversation.
You know, Sarah, I'm pretty sure there's a standardized model when it comes to transferring care between providers. Isn't there something similar for consultation?
You know what, Dave? Fortunately, there is. The 5 C's model. The 5 C's was developed to optimize consultation by structuring communication. There are 5 steps.
Yes, and the first C is contact. Each party should state their name, their service, and role on the team.
The next C is communicate. Verify the patient's name, location, and medical record number. State the diagnosis that's been confirmed or that you suspect. Provide them with a brief synopsis of the history, physical exam, and any ancillary data that you might have. Share any interventions you've made and any response to those interventions.
The next C is core question. Be clear up front why you are calling the consult. Are you calling for an admission, for surgical intervention, for a procedure, or further recommendations on management? The core question is typically a one-line statement. And an important part of the conversation is also time expectations. Do you need the consultant right away? Are they going to be there in 20 minutes? Or some other mutually agreed upon time?
Next is collaborate. Ask the consultant what questions they have. Ask if they need any additional studies or therapies prior to evaluation. For procedures, you can ask if they need any supplies to be at the bedside.
And the last C is close the loop. Review any actions that you're going to take prior to the consultant's evaluation and review the actions that the consultant is going to take. And thank the consultant for his or her time. You know, Sarah, this got me thinking, if only the emergency physician had closed the loop on the onions.
Yes, if only. But now let's turn to some examples to further illustrate the 5 C's, an effective consultation in the emergency department. Let's start with a straightforward case where we have a medical student call a consultation.
Hello? Oh, hi. Thanks for calling. My name is Thomas Yang. I'm a medical student. I'm working with Dr. Paradise from emergency department. Is it surgery?
Yes, it is. What do you have?
So I have Miss Camis here.
She came to the emergency department for abdominal pain. It actually started yesterday. She said she vomited about a few times, but no diarrhea.
And the pain is actually on the right side.
But she states that the pain was actually 3 out of 10, but now 7 out of 10.
Sorry to interrupt, but why are you calling me?
Oh, because we were worried about her having appendicitis, and CT shows she has appendicitis.
Okay, well, I'm really busy, but I'll be down as soon as I can.
Oh, okay. Sorry about that. Thank you.
Well, Sarah, the student did ultimately attain the consult, but I feel like there's some room for improvement there.
I agree, Dave, definitely. In this case, we want to highlight the importance of the core question and communication. Remember, consultations are different than patient presentations. They're a specific request. With that goal in mind, you should lead with the problem or question up front so the consultant understands what you're getting at. This will help engage them in the process.
To follow up on that point, keep the clinical information you present to what's relevant to the consultant's decision-making. Just think about, what would you want to know if you were on the other end of the line? Be selective and succinct in the information you provide.
So let's try this case again and see what a more effective example might look like.
Hello, Thomas Yang from Emergency Department.
Yes, this is Dr. Swanson with General Surgery.
Thank you so much for calling me back. I'm the medical student who's working with Dr. Paradise, and I'm calling you in regards to Miss Camis, who has appendicitis that was shown on CT scan.
Okay, MRN.
8675309. What's her story?
So she's a 43-year-old female with no prior surgical history, came to the emergency room for right lower quadrant pain that started 12 hours ago.
She had a temperature of 100.7.
But vitals otherwise were unremarkable. On exam, she's tendered to right lower quadrant area, but no rebound, no acute abdomen. Her white count is 13,000, and we ordered a CAT scan, which confirmed that she has appendicitis.
Okay, and what have you done for her?
So she has been in MPO for 6 hours. We've given her 1 liter of IV fluids, and we're ordering antibiotics right now. Do you need anything else for us to do?
Nope, that's all I need. I'm finishing up another consult, but I'll be just down to see you here in the next 15, 20 minutes or so.
Okay, thank you so much for your help.
Wow, Dave, that was a lot better. By the time of consultation, they'd already established a diagnosis of appendicitis, and the student made that clear up front. He did a really nice job staying focused and on track while avoiding extra unnecessary detail.
Now, let's move on to another example. Some consultations are straightforward. The diagnosis and management are clear. But there are other consultations where there may be a difference of opinion between providers. And based on the nature of the issue, the potential for disagreement is predictable.
Yeah, when this type of situation arises, thinking about how to collaborate with the consultant can be particularly important. Here is a scenario in which a senior resident is taking care of a patient with congestive heart failure, who is well known to both the emergency physician and the cardiologist. However, there's kind of some uncertainty whether the patient truly requires admission. Let's take a look.
Paging Dr. Smith, you have Dr. Talia, cardiologist, on the phone to speak with you.
Hey, thanks for calling. This is one of the ED residents calling about an admission.
Okay, what's the story?
Well, Mr. Jones is back. He's in a heart failure exacerbation. I think he needs to be admitted.
Again? I just saw him in clinic last week and he was doing fine. Has he been taking his medications?
His meds? Yeah, I think so. I can ask him. But he came in, he was short of breath. He was pretty hypoxic. I think he was, give me 1 second. Yeah, it looks like he was about 92%.
We gave him some Lasix, we put him on some oxygen.
I think he really needs to be admitted.
You know, every time we admit him, we just give him a few doses of IV Lasix and we discharge him. You guys could do that in the ED and then have him follow up with us next week. His labs look okay, right?
Yeah, his labs look fine.
I think that'll be okay with me.
I'm happy to treat him. But, you know, I'm not sure where he's going to shake out over the next 24 hours, so I'd feel a little more comfortable if he was admitted.
Well, just have him call my office tomorrow for a close follow-up soon. I don't see a need to admit this guy right now. Let me know if you have any problems.
Well, I was hoping the consultation would look better than that.
Me too. I wonder if the emergency physician had a better handle on this patient, it would have gone better.
Yeah, let's rewind and try that again.
Paging Dr. Smith, you have Dr. Talia, cardiologist, on the phone to speak with you.
Hey, thanks for calling.
I'm down in the emergency department. I'm one of the second-year ED residents. And I'm calling because Mr. Jones, one of your frequent heart failure patients, is here in decompensated heart failure, and I think he needs admission.
Okay, yeah, Mr. Jones. His MRN's 543-2130. I just saw him in clinic last week. Why is he back today?
Yeah, I know you know him well, and I've taken care of him before too, and I know he frequently comes to the emergency department in heart failure. But today I'm just a little bit concerned because he looks a little worse. He came in, he was in moderate distress. He was hypoxemic to 90, 92%. He was also hypertensive to 190 over 100. He had bibasilar crackles on exam. His chest x-ray did show pulmonary edema. We checked his troponin and an EKG, and that was, those were normal. But, he hasn't really gotten all the way back to baseline with some nitro and some Lasix that we've given him.
Yeah, he comes in all the time for this. Usually he misses a couple doses of his medications, his blood pressure skyrockets, and he gets flash pulmonary edema. Once you get his blood pressure down, restart his home medications, he's going to be fine. It'd be nice to not admit him and get him home.
Yeah, I completely hear where you're coming from, but today I feel like it's a little bit different than in the past. He's gained 5 pounds. He has been taking his medications. I've even asked his wife. He has some worsened pedal edema, and I really think that he could benefit from an admission. I think maybe a little observation, some diuresis, and maybe even a repeat echo could do him a lot of good. Would you mind evaluating him at the bedside with me?
Okay, that sounds reasonable.
Is he on a nitro drip, and have you given him Lasix?
Yeah, he was on a nitro drip. We're titrating him down on that currently. We've given him 40 of Lasix, and he's put out 200 cc's of urine.
Continue weaning the nitro drip and give him another 40 of Lasix. Sometimes it actually takes a high dose, like 80 milligrams, to get a good diuretic response. Let me finish this other admission, and then I'll be down.
15, 20 minutes sound good to you?
Sure, I'll see you then.
Yeah, that sounds great. We'll continue to down titrate the nitro. We will give him another 40 of Lasix, and we'll see you down here in 20 minutes. Thank you so much.
Well, that was a nice display of partnership. The consultation was much more effective.
It really was, and it helped that the emergency physician knew the details of his patient, was able to outline specific causes of concern, spoke the language of the consultant, and was also able to articulate what would be accomplished through hospitalization.
Everyone stayed professional and listened to each other.
There was also good closed-loop communication in confirming the next steps.
And seeing patients together at the bedside offers many advantages. It brings more personable face-to-face interaction. It enables both parties to confirm the history and exam and the recommendations as far as the patient being the most important person in this.
Absolutely. So let's summarize what we learned today.
Remember the 5 C's as a standardized communication model for consulting in the ED.
Make sure both parties have clearly identified themselves and the patient being discussed.
Please be clear up front why you are calling and what is the issue or question you're asking. If the diagnosis is known, share it at the beginning of the call.
Know your patient well and have key data and details in front of you, but be concise in the information that you present. Always think about what your consultant needs to know.
Learn the key pieces of information for different specialty, such as EKG for cardiology, NPO status for surgery, and visual acuity for ophthalmology.
The more you speak the language of your consultant, the more confidence your consultant will have in you.
Close the loop to avoid errors, particularly when actions are being recommended.
When there's a disagreement, it can be helpful to request to get everybody together at the bedside and confirm that everyone's on the same page.
Remember, always maintain your professionalism. We work together, not against each other.
Pizza's here.
Oh, delicious. Yes, bring that over here.
So hungry.
Wonderful. Yeah, let's take a look.
Oh,
No onions.